I'm going to tell a little story as the panel comes up. So about 12 years ago, a group of innovators in primary care met in St. Louis at an airport hotel for what at the time was kind of the first convening around this novel concept of direct primary care. Since that time, the practice model and the innovation has grown leaps and bounds. And today we're really happy to feature a conversation about direct primary care in its second decade. And I am happy to introduce from Elation Health, Sara Pastoor, who is a good friend and collaborator and a partner in Primary Care for America, who's going to lead this panel. So Sara.
Well, it's so good to be here, and I'm so excited to talk to this panel of experts today. I think that this is going to reveal some really powerful and interesting innovation that is happening in the primary care space that many people maybe don't even know about. So before I let my panelists introduce themselves and tell us about the work that they're doing, I just wanted to kind of set the stage here. I'll start by introducing myself. I'm Sara Pastoor. I'm a family physician and a part-time DPC doctor. And then in my day job, I am the head of primary care advancement for Elation Health, which is a primary care focused electronic health record company. And so I was really interested in listening to our previous panel talking about innovation, and innovation is so important because what we've been doing is not working. And they say that, necessity is the mother of invention, no shortage of problems to solve in healthcare today. And so enter the direct care revolution. We have so many opportunities to fix things that are broken, and we really need to pay close attention to those things that are working better than the things that we've done before. And so direct care started small and mighty, but today it is growing by 31% every year. I read recently that 35 million Americans are being taken care of in the direct care model, and the direct care workforce is doubling every 3 years. So broadly defined, direct care is prepaid primary care, usually in a monthly membership model. And I'm hoping that we'll be able to talk about the different ways of who pays, and I suspect we may have some strong opinions on our panel about what's important about who pays, so that'll be an interesting thing to discuss. But at the end of the day, this is not an experiment anymore. This has really taken root, and it is evolving quickly, and we need to keep our eye on it. And so the important thing about direct care is that it really is about eliminating those misaligned incentives that have driven healthcare spending wildly out of control, that have left us with a healthcare system that produces outcomes that are very poor relative to our peer nations, embarrassingly poor. And so how can we get better outcomes at a lower total cost of care? And so employers are actually paying up to $2 trillion of our $4.5 trillion national healthcare expenses annually, and they are desperate to rein those costs in. They're going up every year. And so employers, both large and small now, have started to take note of the incredible power of primary care to bend that cost curve and improve outcomes. And so now they are starting to build their benefit plans on a DPC backbone. And so direct care is finally now starting to really scale, whereas previously it was expanding very incrementally in the individual marketplace. Now we're seeing this huge scale happening, which opens up a whole new opportunity for risks to manage and problems to solve. And so we're really hoping to have some good conversations about that today. And so as a result, direct care is now reaching more consumers, and that is, I suspect and hope, beginning to change the culture around what healthcare consumers, patients, expect and demand from healthcare and from primary care. And so as patients begin to expect and demand more, we will see a more demand for this in the marketplace, and hopefully that will then continue to spark more scaling and more expansion of the direct care model. And certainly we are not going to run out of the need for that anytime soon. So having said all of that, I will pass this along to our panel members to introduce yourselves, please, and then share with us what your particular area of focus is in the direct care landscape.
Great. Well, good afternoon, everybody. My name is Michelle Neblett. I am the Director of Healthcare Policy for the Boeing Company. My job is a federal lobbyist here in Washington, D.C. My job is to advocate for the company on healthcare, retirement policy, and other employee benefits. Why am I here? I think that'll all become clear as our conversation goes on, because Boeing is very involved in direct primary care and the legislative process. But just to back up and give you a little bit of a perspective on who Boeing is from a healthcare lens. We do have 170,000 employees worldwide. 95% of those are here in the US, and that translates into over 450,000 lives covered by our health plans, both active employees and their dependents, as well as early retirees, post-65 retirees, and their dependents. So we truly have a wide swath of population. We are in every state. We have employees in every state. Sometimes it's 2, sometimes it's 60,000. So we run the gamut, and we need to provide benefits and care for those patients across the country. Back in early 2000s, you may recall employers had really high healthcare costs, year-over-year increases that we were seeing. And Boeing decided at that time the way we were going to look at this was through primary care. And we did a study over 2 years in the Seattle area with almost 300 employees who volunteered, and found that this intensive, highly integrated, highly coordinated model of primary care, lots of communication with the patient, resulted in a 20% reduction in healthcare costs by avoiding the ER and hospitalizations. It improved health outcomes dramatically, and it increased productivity more than 50%. That was all we needed to see, and that started our journey to direct contracting with integrated hospital systems, and then in 2018 to direct primary care. So it has been a journey. It's something that we're very much invested in terms of the primary care model and what it can do for prevention for employees, for their lives, their health, but also, as you said, Sara, the reduction in healthcare costs.
Thank you.
Hi, everyone. I'm Dr. Jeff Davenport. I am a family physician. I've been practicing direct primary care since April of 2014. It occurs to me probably too late that I should have powdered this thing, because I don't know if you can see all these beautiful people with all the hair up here through the light off of the forehead, but I'm president of the Direct Primary Care Alliance, which is about 6 years old. It's an alliance of direct primary care physicians, and we have a much more eloquent vision and mission on our website. But I like to say that we are an organization founded by DPC doctors to help doctors transition into a DPC practice to take care of DPC patients. And my dream is to eventually break the system and recreate it. One of my favorite sayings that I use in many of my talks is a quote by Orrin Harari, which says, "The invention of the light bulb did not come from repetitive attempts to improve the candle." So that's what I'm here to do today, or help do today.
Thanks, Jeff.
Hi, I'm Mark Tomasulo, family physician. I started a direct primary care practice back in 2014 and grew that into a fairly significantly sized DPC practice. Was acquired by One Medical and then subsequently acquired by Amazon. So currently I'm the head of direct primary care strategy and innovation for One Medical, which is an Amazon company. really to try to solve some of the solutions for scaling and changing primary care from fee-for-service.
Thank you.
My name is Jonathan Bushman. I'm family physician in Enid, Oklahoma, community of about 50,000. We have a clinic with 4 clinicians, 4 staff members, so 1 full-time employee per provider in our DPC clinic. We also operate 3 other clinics with independent providers through our MSO. And that was the second hat. My third hat is in the last year and a half, I joined the Health Rosetta, which is a group of advisors nationally that work on high-value health plans for employers. So I've entered those conversations in those spaces with employers on a different level, coming from the clinical background, but able to speak the language of the HR directors, the CFOs, the CEOs, the people who are in the positions like Michelle saying, hey, we know what you're looking for. Let us work together to fix this together.
Great, thank you. So when we talk about direct primary care and aligning incentives, I'm interested to hear the perspective from each of you about how those incentives align, how you're building that incentive alignment into your programs, and how you are, what are your outcomes that you're looking for? And do you measure those? What are your struggles around that? Like, how do we get all of this aligned?
The measurement is very important, obviously, and we have a lot of experience doing that through our contracts with the hospital systems, and we've taken those learnings and have brought that to primary care. In those direct contracts with the hospitals systems, we had a number of clinical metrics as well as patient satisfaction metrics. And so those metrics have followed to the DPC contracts, and that's part of that outcomes-based. You know, are we improving patients' health at the end of the day? Are we, taking a look at, whatever the disease or the diagnosis is it? Are we improving all of the measurements associated with that? But very specifically too, it's about patient experience. And if we can change the way patients experience the health system, change the way they have a relationship with their primary care doctor, but also the whole practice, I think what goes into that, it is transformative, I think, as the last panel was talking about, in terms of how patients see and view healthcare and how they access it from then on.
Do you have examples of some of those measures?
You would say one of the measures, for example, that we were able to put in place with the hospital systems that we saw a dramatic increase change in was even just depression screenings. Are you doing depression screenings? And so focus on the mental health side of things, integrating that into the primary care setting. That's just one of many, but it's your clinical, your cholesterol levels, your blood pressure, your those sorts of measurements that you're looking at.
Thanks. Jeff, what are your thoughts?
I think one of the metrics that's probably the most hard to measure is just the amount of time. To me, one of the biggest issues in primary care these days, typical fee-for-service, practicing 25 to 30 people in a single day, which, by the way, I was in fee-for-service before transitioning to direct primary care. So, my worst day ever in 10 years of direct primary care, I saw 12 people. And I used to see 12 people a half day every half day. And so therein, to me, is one of the things I would say about metrics is I just think primary care is so difficult to measure in an objective fashion. We were talking earlier, as you guys know, about one of my patients. Took me 8 years to get a bilateral amputee who had a heart attack and was a diabetic to quit drinking 7 liters of Sprite a day. 8 years. What do my measurements look like for the first 7 years? So I've always felt like time and access, the availability to contact the physician, the technology that we have these days. I mean, my daughter, my wife can contact me immediately any point of the day. It's called a cell phone. Maybe you guys have heard of it. I think the technology is out there. The thoughts of investments and all this technology inside the office, those discussions kind of confuse me sometimes because everyone has FaceTime, Teams, Zoom, everyone has texting, phone calls, emails. We all have the technology to interact with our patients in a variety of fashions at any point in time. I've been sitting at that table over there taking care of patients right now today. How do you measure that? I don't know how. So I've never been a huge fan of discussing primary care in terms of metrics. I do understand on a more global scale how it's hard to measure. How good is the primary care? I get it. How do you measure that? I don't really have an answer for that, but to me, saving the doctors out of a broken system where they're committing suicide at a rate on the level of first responders is to me one of the main goals of the Direct Primary Care Alliance. If we can save the physicians, provide them an opportunity to take better care of their patients where they're not seeing 25 people a day, and the patients at the same time have a significant benefit of having access and capability of interacting with their doctors directly, getting in within an hour, communicating within an hour. Those types of things aren't really measurable, and if we can help save those doctors, then in turn it helps to save the patients, and in the long run it helps to save the system, and that ultimately saves money. And that's kind of what drives the whole world, seems like. So, but I'm kind of trying to start at that top level and work my way down. The money will follow the care if you do it right.
Excellent. How about you, Mark?
Sure. So I think the interesting part about when I started in this space of direct primary care, there were very few of us, maybe a couple hundred across the country. And we didn't really care very much about metrics, but what we started realizing very quickly, those of us that got involved in the employer space, so we all started on the consumer side. I don't think there's a DPC practice that didn't start on the consumer side. And then very quickly, a consumer has a business. Hey, can you take care of my employees? And then that kind of snowballs into larger organizations to where you're taking care of thousands of employees. And I think what we really started unpacking when you looked at data, claims data, and some clinical data, but really claims data, because that's where the beauty exists inside of what metrics you're looking at. What does it all lead to? Does it lead to a decrease in total cost of care? Not primary care, not specialty care, not advanced, imaging or specialty. It's total cost of care. And what does that look like? And what we really started seeing, and the metrics that we really started focusing and paying attention on, is access. And so anything that you can do to change the barrier of a patient to access their physician, so $0 copays or no or small copays, if you have to cover the first dollar coverage issue, which we're trying to solve here in this state, and Michelle has been a great part of that. But it's all about how do you change the access point for a patient, and then the experience that the patient has in there. So if you have a patient that comes into the clinic and waits 20 or 30 minutes to be seen for 5, the experience is horrible and they'll never come back. And so they find different ways to serve themselves, and that tends to be in a higher cost of care. So what we really started measuring was access. What was interesting about the access metric is when we showed that we had 60 to 70% utilization of a panel, we started seeing drivers in terms of how they utilize the clinic. So I'll give you just some numbers. Traditional fee-for-service, a patient sees their doctor about 1.4 to 1.6 times per patient per year. It's national average, that's a fee-for-service number. In direct primary care, we were seeing numbers in the 20s, 20, 21, and it wasn't because they were coming face-to-face. It was because we had unfettered access. So to Jeff's point, you have a cell phone, you have text messaging, you have emails, you have video conferencing, like secure platforms. Like I wouldn't, unsecure platforms are not the way to go about it, but secure platforms. And so when you see that you're having 4 to 6 face-to-face visits, and then the rest are all technology, it's still 20 types of encounters compared to the 1.4 to 1.6. And what that does is translates into a reduction in total cost of care, depending on the cohort and the population that you're serving. So in my mind, the most critical component of any metric that we're going to be looking at is how do you provide access to the patients and how often are they utilizing you? And that will translate into a lot of things downstream.
That's right. Go for it, John.
Yeah, sure. It's interesting how 3 previous answers can make you like develop a different answer than you thought you had. But just to be clear, it was my privilege to meet Dr. Pastoor a little over 2 years ago in response to my question about how to pull data out of our EHR to prove my point to an employer. Because this employer, CFO, is looking at $2 million in spend. We initiate DPC. Now we're $2.2 million in spend, and you're supposed to save us money, so tell me what you did, right? And it was a perfect question. It's a very legitimate question that any reasonable CFO or decision maker, purchaser, employer is going to ask is, I need some sort of proof, I need some sort of evidence of what you're doing. And it was an interesting conversation I had with him that day because he wanted to go immediately to patient visits, which is completely transactional. And I'm like, this isn't going to show us what I didn't have the metric to show, but we've had 18 touch points this year with each of your people. I didn't have that right on my fingertips. And it really made me question, okay, I've got to be able to show this. I've got to be able to show what I'm doing. And I started looking for those measurements myself as well. And what we landed on that we really, really enjoy using is the person-centered primary care measure, which is a 16-question measurement tool. And it really is focused on the patient experience. So what we know that is if we've removed the barriers, whether that's copay, et cetera, we've removed the barriers, they can text us. We've done that part just on the design, on the front end. On the back end, what has happened is we've enhanced the patient experience and lowered even the emotional barrier to care that they once had, right? No longer is it something I'm worried about connecting with my physician or how long it's going to take or how much it's going to cost. Now we start asking very legitimate questions that never did get the time of day previously. That is hard to measure. I mean, there isn't a tool for that. But it comes through in various forms. One would be patient experience, one's access, one's lack of barriers. So when you kind of think, everyone has mentioned that. You talked about the access, you talked about the experience, right? And just the touch points that we have. Those really are all important. And somehow, if you could aggregate that into one single measure, it would be wonderful for all of us. But it is a very, very, that data point, I'm not sure it exists. It's my thought.
What I love about the PCPCM or the person-centered primary care measure is that it's a patient-reported outcome. So the patient takes the survey, and then the patient rates their experience with the practice based on, does my doctor know me? Do I feel like my doctor knows me? Does my doctor advocate for me? Does my doctor talk to my specialists? And coordinate care? Do I feel like I can get care from my doctor when I need it? They don't specify how, but can you get care from your doctor when you need it? So those are really the core aspects of primary care that change how patients experience care and then change those downstream care measures that we've been talking about. So we had a really interesting talk this morning about continuity of care, which I think is so important and one of the things that direct care does really well. And so we've got this a couple of generations now of younger folks who maybe don't value that continuity as much as they value convenience. We talked about this a little earlier, John, and because they've been raised in a digital age. And so everything is very immediate gratification. And for those folks, they may be more likely to choose convenience over waiting to receive continuity. And what I love about direct care is that you get both. You get the continuity, and you also get the convenience. And each one of my direct care colleagues in the room today has been taking care of patients while we're here, texting with patients and managing patients. So no matter where you are, you can make sure that your patients are getting access to you and the care that they need. I'm imagining that that can be, the integrity of that process can be difficult to protect as we scale. In a small practice where you've got 1, 2, 3, 4 docs or whatever, that's easier to do. No one's available 100% of the time, obviously. We have to come to conferences and sit on panels. But as we scale, I'm interested to hear from those of you with experience, how do we protect the integrity of that so that our patients can continue to get that direct care experience of both continuity and convenience with their PCP, which is so important?
I think, well, I could tell you at every iteration of growing an organization, it takes on a new meaning of how do you maintain the service and experience throughout the service that you're providing to an employer or an individual. And so, to your point, when we had 2 or 3 physicians, it was super simple. When we had 2 or 3 offices that were 40 miles apart, it was almost like they might as well be in different states because they assimilate into what their population is telling them. They assimilate into it. They take ownership of that practice, although it's a one practice. Not, it takes a lot of energy and effort to maintain a standard that's across the board that represents your brand or your company in a way that if a patient goes to clinic 1 or clinic 2 or clinic 20, they experience the same thing. I think that went on for years, and it was a constant challenge. I think One Medical, as an example, hundreds of locations. I think you change how you start looking at making things accessible and standardized and what that care team looks like. So last panel was talking about a care team. When you have 2 or 3 providers, you're the care team. I don't need a whole lot of people assisting in the care team because you have the bandwidth to do that. When you have hundreds of providers and now tens and tens of thousands or hundreds of thousands of patients, you need a care team that covers a 24/7 spectrum, maybe a little bit different. But you have to have a standard inside the organization in order to make sure that everybody is getting the same service and the same care regardless of where they're going. But I think the foundation of direct primary care, that is the standard, right? As long as you have this foundation called direct primary care, there's an assumed foundation that is fairly solidified in the community, that you have to do certain things in order to be part of the direct primary care community. And I think that sets a standard moving forward. So like Michelle's company, when you're in every state of the country, that their employees don't have disparities from going to Arizona or going to San Francisco or going to Colorado. They all have the same experience, the same benefit, and the same options. And I think that's extraordinarily important.
Do you then measure performance against those standards?
I think so I'm going to give you my, the right answer is sure. You do want to measure those things, but to the point that you don't want to get lost in the data to understand that there's actually a patient and a person and human being behind that data, and every experience is a little different, to the point that you want to be able to report to an employer what's happening within their group. And that may look different from one location to another, but you have to be able to create that data point that aggregates the entire organization as a whole. And depending on the locations and the geography, those things might change. So trying to hone it down into one particular point that you can point to and say, hey, this is what we're doing, it's almost near impossible. So you have to look at the aggregate level and understand what you're looking at. And that's why I think you need to see the entire spectrum, claims data, clinical data, and then patient data to really pull the story together to see what points really matter versus arbitrarily saying this is the point we're going to look at and it may or may not really have an impact you're needing.
Other thoughts about this?
Yes, actually, I'm glad you brought that up because what I'm thinking of is, and I recently had this discussion with an employer. They asked for reporting, like what kind of sample reporting do you, rather than just saying, here's a sample report, I said, I want to know what it is that you would like. What's important to you? Is it, are your employees having trouble with access? I'll give you some access numbers. I'll give you some some expectations on that standpoint. But I need to know what it is for you. So, and I was just going to mention this too. One of the beauties of getting into the advising space, which sounds like an entirely different career, in some ways it is, but it's the exact same language. It's as if I'm sitting down with a new patient. I'm taking a history, like I would with an employer in their health plan. I'm taking the history, tell me where you're at, how you're doing, what problems have you been facing, and they're going to tell me what their problems are, and I'm going to be looking at them thinking of solutions that I can bring to help them. So it's really not different mentally for me to approach an employer than it is with a patient. But along this same conversation, I want to ask the patient or the employer, what is it that you want to measure here? If you're diabetic, I'm going to measure an A1C. If your blood pressure's high, we're going to measure your blood pressure. There's certain metrics that I'm going to follow based upon that patient's need, just like an employer's need. So I think it kind of comes down to who's paying the bill, who cares? Like, what do you care about? If you don't care about the measurements and it's just an all relationship-based thing, we don't need to be reporting to each other. If there's something more to it or something that's really important to you, let's hone our metrics based upon your needs, based upon your desires.
I would just add something to that as well, and it's an extraordinarily valid point. The size of the employer is truly dependent on what needs that employer might have. You have an employer of 20 employees, they don't really care too much about data points. They want to know that their employees are taken care of and that they love you and that they're providing a phenomenal benefit to their employees. You take that same employer and you say it's 20,000, that conversation is important, but they're also paying you tens of millions of dollars, so you have to have some points of interest that show that you're generating an ROI on that. What we found, what was really interesting when we talk about data, just purely data, and you're looking at claims data and clinical data, there's a massive disconnect of interpretation. First off, the data is not standardized, so trying to get data in an aggregate level is almost impossible because they all have different ways of reporting it. So standardizing the data is really, really difficult to interpret what's happening. The second thing is that we started seeing, because there's a disconnect of transference of data from clinical to claims to TPAs as an example, that when you just give data to somebody that's used to seeing fee-for-service data, the data is interpreted wrong. And so I'll give you a prime example. We had a great relationship with Cigna for a really long time. Cigna would look at our data and say, well, you're not doing your screenings, you're not doing your cancer screenings, you're not seeing your patients, often enough, or the measures that we're looking at on a claims data isn't translating, but there wasn't a feed of clinical data to claims data, so they weren't even seeing the clinical side. So when you report that back to the consultant or broker, and the broker goes back to the employer and says, well, it doesn't look like they're doing very much, you then have to start educating people how to look at data differently than what we've done over the last 30 and 40 years. And so you'll see a decrease on the claims side, but you'll see an increase on the clinical side. And if they don't communicate with each other, Cigna would look at this data and go, holy crap, we have time bombs sitting on our hand because we have a bunch of patients that are not getting the care that they need. So we're going to increase your premiums. And we're like, what are we talking about here? So the transfer of data to understand the impact that direct primary care has on the patient is still difficult to obtain, especially in smaller practices.
Yeah, and it really is a paradigm shift too. It's not just about the data, it's about how we think about healthcare and the role that primary care plays, and the fact that, in the primary care practice, we're not submitting claims in the DPC practice. So lots to look at there. It's interesting that we keep circling back to this idea of measurement, and I think that is tightly tied to who pays, and John, you brought that up, so I want to get some opinions here about, is it important who pays, and how does that inform the care delivery process in a direct care practice? And I want to start with you, Jeff.
Actually, it's kind of very interesting, not picking on my colleagues here, but I heard the word data 47 times, I think. I didn't hear the word care very much. And I understand we're talking on a global level, much larger businesses, but even our business colleague up here was talking about downstream spend and how they've recognized that direct primary care or some kind of a membership style practice has significantly decreased the financial burden. Am I correct on understanding
That's
your
correct.
opening statement? And yet we're sitting here over here trying to figure out a way to prove it to them. Well, I mean, she's already knows it. Like, what are we trying to prove here? Now, maybe that's just one company, and we're trying to figure out, well, how can my large DPC organization prove that I'm better than the next large DPC organization versus just understanding that DPC in and of itself is the solution, and it may not matter that much whether it's DPC A or DPC B or DPC C. So one of the concepts that I think, if I were an employer, what I would figure out how to do is how to empower my employees to go find a DPC doctor and not figure out which DPC organization to pay for directly. I've always felt like figuring out some way, whether it's a benefit card or it's kind of like food stamps. We give them the stamps, they go buy the groceries wherever they want to. Something along that nature. Allow the employee to figure out where they want to go to find the DPC practice rather than saying, okay, well, this DPC entity A has 47 locations and there's 211 people and they're going to charge us X number of dollars per month and let's go with them, thereby limiting the employee's access to DPC as a whole down to only the one network or something of that nature. And how are you going to try to decide whether to go with them? Well, you're going to look at their data. And to me, that's not even what primary care is about. It's about that doctor-patient relationship, and neither one of you is the doctor nor the patient. It's the owner of that DPC corporate strategy and the company. Now, the company wants to be financially wise. They don't want to waste money. They want good care for their employees. But it's really the employees who should have the majority of the power, especially with respect to direct primary care and finding their own doctor. Because what if their doctor isn't in that group that you just chose? And that's what I would encourage any corporation to figure out how to do. If there's going to be government payers out there, I was on a panel 8 years ago in Texas, and that's what we were all saying. It's like, look, empower the citizen to have the ability to find their own doctor and have that relationship and get that care. And I still think that I do love the concept of the patient-centered assessment, but even the company and the HR within the company can do that. It leaves the physician out there actually taking care of people rather than tracking things.
Other thoughts?
Yeah, well, I would say, we would love to get to a point where it's employee-driven and there is a lot of choice out there, and we provide the incentives for them, which is what we're trying to do in our starting down this DPC road, right? We've been at this since 2018, and I think we'll talk about growth and barriers and all that, and there's some things there that I think are preventing us from getting to that point that you're talking about. We're not trying to limit anybody in terms of who they have access to. We're trying to present them with, look at this alternative to a fee-for-service primary care path. Look at this direct primary care experience. Hear from your colleagues how they've experienced it. And here is one practice, but as we grow, we can expand in terms of the network and who we are working with and who we can put in front of our employees and their families. So, in terms of who pays, the way the employer model works and is, and as a self-funded employer, right, it's our dollars, but it's also our employees, our plan participant dollars. We're not trying to get in the middle between the patient and the provider. We're trying to help facilitate that and make that a no-cost proposition for the patient, so that we'll do the contract, we'll work out all the behind-the-scenes stuff. You just go access your care as much as you need, and it's all taken care of, and there's no additional cost.
Nice.
I think the purest form is between the doctor and the patient. Okay, I mean that's how direct primary care was brought into existence. And as you mentioned, Mark, earlier, that almost every DPC practice out there started as an individual or family-based, consumer-centric, not necessarily with employers, right? And so in those relationships, I'm accountable to the one, or I'm accountable to the family. And that is so direct that it's so service-oriented when you know that that person is paying you. And it's kind of funny when we talk about, I'm not going to use the word again, but those things, we look at that and go, well, how do you say, how do you know if your patients are satisfied? And I go, well, I have 100% satisfaction. How do you know? I didn't measure that. I know because they're still there and they're still paying the bill and they still show up. Okay? That's so pure. I don't need any report for that. Now, does that mean I can't do certain things better? No. And that's part of what I measure myself for, is to say, what am I not doing quite as well as I could for my patient's sake, not necessarily the payment sake. But when it comes to who pays the bill, we add in the employer space, right? And we add in even third-party payers, which whoever that third party may be. And you started us out very well, Sara, when you said we have to have the incentives aligned. Because if your incentives are aligned, the dollar flow doesn't make a huge difference. Now, where we've seen that get messy in other payment forms and the traditional fee-for-service world we came in, is that those third parties put certain incentives in that weren't healthy for us relationally with our patients. That's why most of us left that typical system. But more than that is, if you have the incentive, or if there's an incentive maybe by an employer, and I'm talking a physician employer, provider employer, sometimes there's policies created at the government level that intuitively you go, that's fantastic. That's going to do it. The trouble is the dollars flowed into another health organization that then put a contract between them and the clinician, and the incentive that had been created in the policy didn't translate into the exam room. That's my fear when you add in certain levels, is that somewhere in between, if you do have an additional party besides the patient, at least you run the risk of losing the shared incentives.
Yeah, that makes sense. Very well said.
I would, the thing that I've realized over the last 12 or 13 years is there is a spectrum of primary care. Fee-for-service is on this end of the spectrum. DPC is on this end of the spectrum. And so that's what Jeff is describing, is kind of this end of the spectrum. And fee-for-service is way over here. I think we all started on this end of the spectrum on the DPC side, which was the direct patient provider contract, direct primary care. Although Garrison Bliss moved into the Medicaid space pretty quickly as a payer system, lots of dysfunction, reasons why, and there's a whole nother conversation. But here's the point. We can't stay on those end of the spectrums. You can't. This one is broken and this one is too immature. Somewhere in the middle, you have to start moving people off of the extremes. And I think this is where DPC is starting to find its calling, or find its area of expansion and rapid expansion and opportunity to growth. Now, over 70% of all healthcare is paid for by employers, and most of those that pay for it are self-funded. So the conversation of the patient and the doctor contract is just, you throw it out the window. It's on that end of the spectrum. You can't have it until there's vouchers and other things, but that's a government issue. My point is you have to be somewhere in the middle, at least to get off of the spectrum, to maybe move it more to the left side of the spectrum versus the right side of the spectrum being fee-for-service. And so when you talk about employer space, you have to address data. Not because I'm a doctor and not because I love data, but I understood it very quickly enough that you have to speak the language on that end of the extreme to drag them over to the center and closer to this end of the extreme, because what we don't want to do is keep them down there. The last conversation about innovation was, how do we stop fee-for-service? How do we change the payer mechanisms on fee-for-service? There's some great literature and some white papers being drafted right now for legislation to change the way Medicare pays for services. PMPMs are one of those, which is ironically looks very, very close to direct primary care. The point is you have to come to the center and meet people where they're at and speak the language that they know and then teach them a new one. And that takes a long time. And I think on the foundation of direct primary care, Garrison, when he started on this end of the extreme, there was no middle. It was dragged him from that end to this end, and it failed very quickly. So I think the ones that have, like myself, that have scaled DPC to a degree that hundreds of locations across the country, a labyrinth of networks of DPC practices that are independent practice and owned and operated practices, are closer to the center. And I think that's how you're going to grow DPC moving forward, is we've got to get people off of the fee-for-service conversation. And the only way you're going to do that is the Health Rosettas of the world and the Dave Contornos and the Dave Chases, to drag them out of the fee-for-service conversation a little bit to center so we can move them over into this space. And that's going to take a long, long time, but that's the mission.
Well, let's pick up on the scaling conversation then, because I know you want to talk about that particularly, Michelle, and the rest of you probably have some thoughts about this too. In your corner of the world, what makes scaling difficult? What holds you back?
The tax code.
Say more.
Amen.
Which is why I'm here. Employers have, for good or bad, embraced high deductible health plans paired with health savings accounts. I think it's depends on what measurement you're looking at, what size employer, but I can tell you from a jumbo employer perspective, my competitors, there are some out there that have 80% of their folks in those types of plans. In our case, more than 40% of our people choose every year that plan. And they have a choice of HMOs, PPOs, EPO, all of it. And it actually is our highest actuarial value plan. It's great coverage. But the problem is that we cannot offer direct primary care to anyone with a health savings account. That's something like, by some estimates, 72 million people in the US right now. It's a lot of people who you all can't have as patients. So we've been on a mission since 2018 to change the tax code law that would allow us to even offer it. We're not asking that patients pay for it. We're going to pay that bill, that monthly per member per month fee, but we can't even do that. And so to scale, we have been a little stuck the last several years, but have made the decision to go forward and expand. And we're going to have to do it in this hybrid model. We're going to have to do it where those patients that are in that have enrolled in that high deductible with an HSA plan, that those folks are going to have to hit their deductible. We're going to have to run it through insurance first, and then go from there. But we would much prefer a pure capitated model. We just can't do that without a change to the tax code. And so we've been highly supportive and working very hard to get the Primary Care Enhancement Act passed. It went through the House Ways and Means Committee last September on a bipartisan vote. That was the third time it's passed that committee on a bipartisan basis. It's gone to the floor before, the exact same language, and passed on a bipartisan basis as well. We were close in March, I think, to getting it part of the discussion, but the healthcare package legislation narrowed very quickly, and so we're looking at lame duck after the election as our next opportunity. So that is what's holding employers who may have an interest back, right? Boeing's made the decision. We're seen as a leader in this space, whether it was with our hospital contracts or in doing this with DPC. And we've made the decision we're going to push forward and do this and prove it out and scale it. But others are looking and watching to see what we do, how does it work, And they are in the same predicament with these high deductible health plans with HSAs and so many employees with them. So this is the easiest way to get employers and employees into the outcomes-based, value-based care. They're easy, much easier contracts than the hospital contracts that we did. And we really view this as a way to change healthcare delivery, that this is important for primary care, it's important for prevention, it's important for how the system works and to break the system, as you said, right? But we need to change the tax code to be able to do that, to bring all those millions of people in as patients.
Amen. Thank you for the work that you're doing there.
Yeah, I think this is a travesty. I mean, I don't really know how you can have a health savings account that wouldn't pay for a membership-style primary care practice. It's just, the concept is baffling. I just did some research last night. Google knows everything, so I said, Google, what can I pay for with my health savings account? And anyway, you can have cosmetic surgery, you can pay for all your dental and your vision, you can pay for travel if you're going to take your child somewhere, $50 per person per day, so $100 for you to travel into town to take your child to a specialist. You can pay to go to a conference with your health savings account. If it's a chronic disease conference, you can pay for yourself to go to a conference to get educated. The thing that was very interesting to me that you can pay for Medicare Part B, Medicare Part D premiums with your health savings account. You can pay for your insurance premiums. I'll say it again. You can pay for Medicare Part B and Medicare Part D premiums with your health savings account. You can pay for long-term care insurance premiums with your health savings account. And yet you can't pay for your, and I'll use the term even though it's not really a premium, you can pay for your family medicine premium in a direct primary care alliance. You can't do that with health savings account because that type of a primary care plan doesn't look like what we're used to. So we're going to identify it as not an appropriate medical expense. And that to me is, I don't know, it's just silly.
Yeah, I don't, to Michelle's point, we're doing a lot of work to try to get this thing passed. It's not that you can't use your HSA dollars to pay for a membership. The problem is it's a first dollar coverage. Your employer cannot contribute to the HSA, and the patient can't use the HSA to pay for a service because then it puts the patient or the employee at risk for a tax violation. And employers are not going to do that as a fiduciary to their employee. So they either don't fund the HSA or they don't let them participate in the HSA, but nonetheless, scaling is a huge thing for employers in the high deductible health plan HSA issue. My vision of scaling is a whole nother complication. So let's just assume you get the HSAs fixed. Now Michelle has a problem of scaling direct primary care for all of their employees in a way that there might be thousands of DPC practices, but there are 1,000 different DPC practices. So if you've seen one, you've seen one. We have to do a better job in the DPC community of working with each other and understanding the complexities of the healthcare space to where once again, you can't live on the ends of the extreme and then also participate in the middle. So somewhere along the lines as DPC practices, and we did this a long, long time ago, is just collaborating with each other to take care of an employer like Michelle's. Hey, Jeff, you have a clinic. I've got a couple hundred patients that need to be taken care of. Can we make an arrangement together? Having this networked, which is a bad term, right, in a lot of cases, but creating a DPC network of clinics that can service employers throughout the country. One, we don't have enough of them across the country to service every employer. Two, we have to recruit physicians to come into the world of primary care, right? We're not going to do that in that end of the spectrum. On the fee-for-service side, we're not getting
Never
them.
happen.
So we have to solve the problem in a different way. 3, you have to change the way medical schools accept students, right? I mean, we turn more people away from medicine that are actually qualified for medicine because the crop of people that get accepted into medical school are very small. It's a very thin layer. We have to do a better job of recruiting new physicians into the profession of primary care. You have to do a better job of explaining that there's a better mechanism than the fee-for-service environment where you can see 12 people on a really busy day, which is freaking awesome. It's incredible to have a life again. You have to do all of those things to fix the scale issue. So once again, this is not an overnight problem that we're solving. This is a 10-year plan, a 20-year plan. This didn't happen over 10 years. This happened over a 50, 60-year period. We just need to start moving in the direction of fixing it, which is everybody is doing. But scaling from the clinical side is going to take a lot of work, a lot of energy, and a lot of money from a lot of different organizations and people. You just want to be careful with who's involved in that space.
I've got a couple different directions to go with this, but firstly, scaling can happen in 3 different ways, right? In terms of practice structures. So you've got the independent practices or the small independent groups. You've got the employed groups or more of the corporate, even DPCs in certain cases, right? And then there's kind of the in-between. I do a little bit of the in-between. I'm still pretty small, but in through a management service organization, basically saying, here, we're the administrative, the facilitating arm for you to get into your independent practice. And so the clinicians need to know what their options are, and perhaps there's not an employer in their space or in their location geographically that they can partner with, or nobody's willing to just hire them right off the bat. You know, maybe they feel like it's too much risk. I'm in the rural space, these communities are built on deeply rooted relationships over decades and generations, right? So when you have clinicians from those areas, they can build those panels. We have a PA in a community of 1,300 people who has 500 people in her panel, 5.5 years into practice. FQHC 2 blocks away with 3 providers. It works, okay? And it works in smaller scales like that. But she's independent from the legal standpoint, and we do the operations for her. It's fantastic. So I do think that's an arm that can be expanded and can scale quicker, and it's a little skin in the game for the clinician, but also not the risk of not knowing what I'm doing, how to do this, and having the supportive arm to do it. I wanted to mention on students, you said in 5.5 years independent DPC, I've probably hosted, based on my averages, I've probably hosted 50 medical students in that time frame. And they're not all coming to me specifically wanting to go into primary care, and they're not all from rural areas. But by far and away, they always come away saying, I didn't realize family medicine could be fun. Like, I didn't realize that's what this could be like. And now the school, and I got to give credit to Oklahoma State, they're very innovative in terms of trying to get into the rural spaces, the Native American spaces. And they've had me come and speak to the students on what they call their rural track program. So they understand, hey, there's different practice styles, and this happens to be one of them. And the students come out of the rotation with a different viewpoint, just like the patients come out of their exam room for the first time, seeing primary care as different.
That's right. Well, I have 14 more questions, but I'm out of time. And I'm excited that we're going to be talking more about workforce this afternoon, because I think you brought up one of the big barriers to expanding DPC is that we just need more primary care professionals out there. And so how do we do that? I am so grateful to all 4 of you for making the trip here and contributing your profound expertise and doing it in such a collegial way. I learned so much today from all of you, and thank you so much.